Yeah, so if I try to go, let me show you. If I try to go from the to this, it disappears, right?
Yes.
Yes.
But I think that's because your camera is still on. Your camera is
Which
on.
camera?
We can see your camera, like we can see your videos, your face or something.
Oh, you can? Okay. Hello,
Yeah.
everyone.
No, we're not seeing your face right away, but we can see your room,
Shadow.
your shadow or something.
My shadow. Oh, my goodness. Let me see. Okay, please bear with me because I'm not technologically that savvy, apparently. Um, Let me see if I can
Yes, we have it now. Perfect, perfect.
okay, I'll just do it like this.
Yes,
I'll just do it this way
this is just perfect.
because it's too difficult to do otherwise.
Yeah, this is just perfect actually.
Okay.
Okay.
All right. Um so you okay, everyone sees the first slide that says transitioning from 2D to 3D conformal radiation therapy for breast cancer.
Yes.
Yes.
Okay, perfect. So I'll begin now. So thank you everyone for coming to discuss with me. Today I'm going to be talking about the transition from two-dimensional to three-dimensional radiation therapy. And I want it to be an interactive session. If you have questions, just stop me and I'll be happy to discuss. And I don't know if people might type in credit. I don't know if people can type in to chat. So if they do, I'll depend on you because I'm just focusing on my screen. I don't want to take it off.
Okay, sure.
Um, Let me know if anyone has questions.
All right.
So there have been many advances in radiation therapy. From first we had two-dimensional radiation, which was based on bony anatomy. But with the advent of CT scans and MRIs, we were then able to transition from two to three-dimensional radiation therapy. And even since then, for certain parts of the body that we're treating, we can now also utilize four-dimensional radiation therapy, which takes into account motion, whether in the liver, even or in the lung, and also even in sites that you might not commonly think of, like the prostate and the pancreas. So the benefits of three-dimensional radiation therapy are multiple. First, when it comes to planning, we have better anatomical and structural delineation using CT scans and MRIs, especially for soft tissues like the pancreas or the stomach. We're better able to see them. In addition, we're better able to distinguish the tumor from the normal tissue uh, with three-dimensional radiation therapy. Also, three-dimensional radiation therapy has improved how we deliver radiation because rather than just having to use blocks or a square field, we can now better shape the beam since we now have multi-leaf collimators. The other benefit of 3D is in quality assurance, and we can now use image guidance during our treatments, whether in the form of uh, MVs, KVs, or cone beam CTs during treatments. The main benefit of three-dimensional radiation therapy can be described either as we can deliver a higher tumor dose while still sparing normal tissue without further harming normal tissue, or radiation therapy has been improved so that we can obtain a similar tumor control at no additional at a lower cost to the normal tissue. So the whole idea is that we're better able to spare normal tissues and target the tumor. And that concept is described as the therapeutic ratio in radiation therapy. So the main idea is that at a certain dose, as the dose increases, your ability to control the tumor usually increases. But you also have this risk of side effects to the normal tissues, which is usually shaped as a sigmoid. So what we want to do is to push the curve for the normal tissue effects towards the right, so that at any given dose you have a lower risk of normal tissue toxicity and still a high probability of tumor control. So that's what three-dimensional radiation therapy enables us to do. It enables us to push this curve to the right, so that at any given dose your lower hello? Yes?
No, I think that was just a distraction. You can just continue. Ask questions afterwards.
Okay, yes. So that at a given dose, you have a low risk of normal tissue toxicity while maintaining a high risk of a high probability of tumor control. So your complications in radiation therapy, what people define as acceptable depends on a number of things. What's the rate of complications? Usually the acceptable risk level is 5%. Later on, I'm going to describe some guidelines regarding what doses should go to which normal tissues. And usually those numbers or the dose constraints that I'm given will give an approximately 5%, in some cases, 5% risk of severe toxicity. The complications also depend on the organ that's concerned. We may be willing to tolerate, for instance, when it comes to the breast, we may be willing to tolerate a little bit of irritation of the lungs or pneumonitis. But for instance, when it comes to the liver, you're very worried about radiation-induced liver disease, which tends to be frequently fatal. So you probably want to severely decrease the chance that you're going to have radiation-induced liver disease, while you're willing to accept some risk of pneumonitis, which can usually manifests as changes on the X-ray or on a CT scan for patients, and rarely results in death. The severity of the effect, like we talked about with the liver versus the lungs, is another thing to consider. You also want to think about the predisposing factors in the patient. So for instance, when we're thinking about breast cancer, there's some patients who may have lupus or someone who has scleroderma. Their risk of having side effects is much higher than someone else who doesn't have those conditions. Similarly, when we're talking about patients who need treatment for breast cancer, and there's been a lot of interest about what is the risk of heart disease after you've been treated for breast cancer. It depends also on the patient. Does this patient have predisposing risk factors for heart disease down the line? Do they have diabetes? Does this person have a history of prior heart attack? Does this person have a history of angina? So all those things are cardiovascular disease, high cholesterol. Those things are predisposing factors and can affect the rate of complication in that patient. So this is just to illustrate that breast cancer is one of the conditions where we have a high risk of cure. Unlike lung cancer or pancreatic cancer, let's say, in breast cancer, you have a high... Hello?
Yeah.
I can continue?
Yes, sure.
Okay. So in breast cancer, you have a high chance to cure the individual, especially if they come in at earlier stages. So it's very important that we minimize their risk of complications using all the tools at our disposal, which includes hopefully three-dimensional radiation therapy. So when it comes to clinical evidence for three-dimensional radiation therapy compared to two-dimensional radiation therapy, there have been some studies that have been published. So I just pulled this one that was published by a group that gave about 50 gray to the breast And they did it using 3-dimensional techniques versus 2-dimensional techniques. And they found that one, there was improved dose homogeneity. So the volume that received greater than 110% of the dose was drastically decreased by using 3-dimensional radiation therapy compared to 2-dimensional radiation therapy. In addition, side effects like dermatitis, breast edema, and hyperpigmentation were significantly reduced when we use 3-dimensional radiation therapy. So in terms of planning for 3-dimensional, does anyone have questions about that previous section?
Okay, questions? Yeah, okay.
Okay, I can continue?
Yes, please.
Yeah.
Okay, so when it comes to planning for 3-dimensional breast radiation, okay, can you hear me now? I think it
Yes.
muted me randomly.
Yeah.
Okay.
Yeah. Fine.
So when it comes to 3-dimensional breast radiation therapy, I want to talk about contouring, and I also want to talk about treatment setup, how to set up fields, and also plan evaluation. So the first aspect, contouring. There have been some guidelines that have been released regarding breast cancer and how to contour, how to draw out the areas that you desire to treat. So the radiation therapy oncology group put out guidelines, and in these guidelines, they discuss what are the anatomical borders or boundaries for the breast and also for the chest wall. So first, looking at the breast, superiorly, the boundary is around the second rib insertion. But you should also make sure that clinically you are looking for the appearance of any glandular tissue on CT scan. So just because they define it as the second rib, you should still look, because especially women who are larger, their breasts may extend superior to that second rib insertion. So the clinical picture trumps what is described as the usual anatomical boundary. Inferiorly, again, it's what you see on the CT scan. You have to look for the loss of glandular tissue towards the bottom of the breast. So it's kind of a judgment call. Anteriorly, the breast is bounded by the skin. Posteriorly, and this is a big point, you have to make sure that you're not drawing out or including any of the muscles of the chest, the pectoralis major and minor in particular. You also want to make sure you're not including the ribs, because that's not part of the breast technically. Laterally, the boundary is typically the mid-axillary line, and it should exclude the latissimus dorsi muscle. And then medially, the breast extends to where the sternum and the rib join. It should not cross the midline. So just to illustrate this, these are taken from the RTOG contouring guidelines, the contouring atlas, and it just shows again medially around the rib and sternum junction, laterally around the mid-axillary line, excluding the latissimus dorsi muscle, anteriorly the skin, and here inferiorly, they contoured up to approximately where they saw the glandular tissue disappear. And you want to make sure that you take advantage of your sagittal, transverse, and coronal views when you're contouring. Look at it both from the axial view, and also this view really helps to see, do you really have the full picture of the breast. So when it comes to contouring the chest wall. That's usually what we do when we have someone who's had a mastectomy. And in those individuals, the superior border should be around the bottom of the clavicular head. The inferior border is based on clinical judgment. So if the contralateral breast is present, that tends to make it a little bit easier because I will then contour inferiorly to where the contralateral breast ends. But again, also when you're examining the patient at the time of your CT simulation, you want to put a marker around the level where you think on the patient's anatomy the breast would have ended, because that can also guide you when you're contouring. Anteriorly, again, the boundary is the skin. Posteriorly, this time you want to include the pectoralis major and the minor, as well as the ribs, but you don't want to include any of the lung on your posterior contouring of the chest wall. Laterally, again, at the mid-axillary line is where it ends, and you don't include any of the latissimus dorsi muscle. And medially, where the sternum and the ribs meet. So this is an example taken from the RTOG, where again, you can see that the latissimus dorsi is being excluded. And this is actually, this region here is the axilla, the level 1 axilla, so that's why it's not being contoured. And let me continue. So it's very important to also know the levels of the lymph nodes, especially when you have patients who are presenting with locally advanced disease and have node-positive disease. It's very important that we treat the lymph node levels where there may be any microscopic disease, or in some cases, if you have a patient who came in very advanced and you're palliating them, you may also want to include gross disease within the axilla or the supraclavicular region. So I find that there can be a lot of variation in how the lymph nodes are contoured, more so than the breast and the chest wall. So we'll review again with the supraclavicular lymph nodes. They begin just inferior to the cricoid cartilage. So as your CT scan comes inferiorly, you're going to see the thyroid cartilage, below it, the cricoid cartilage, and just after the cricoid cartilage ends, that's where you want to begin your first supraclavicular contour. I find that sometimes people start too high, and that can cause, side effects when it comes to the esophagus, because breast cancer patients do, sometimes get problems with pain with swallowing because the lymph nodes are near that region. So you want to minimize that toxicity. So supraclavicular lymph nodes, the cranial border is just below where the cricoid cartilage ends. The inferior border usually is at the bottom of the clavicular head. Anteriorly, it's limited by the sternocleidomastoid muscle. Posteriorly, the scalene muscle. Laterally towards the top of the contour of the supraclavicular lymph nodes, the edge of the sternocleidomastoid muscle is where you should limit your supraclavicular lymph node contour. And when you get more inferiorly and the sternocleidomastoid muscle disappears, you then want to use the junction of the first rib and the clavicle as your lateral border. And you always want to make sure that you exclude the thyroid and the trachea from these contours, because there is a risk of hypothyroidism. You're not treating the other thyroid, but sometimes it's not enough to compensate, and you just want to minimize the dose of the thyroid as much as possible. So this is just an example of the supraclavicular contour in teal. So you make sure you're excluding the trachea. Superiorly, the thyroid has ended, so you make sure you're excluding the trachea. This is the sternocleidomastoid muscle. A little bit is poking out just anterior to the supraclavicular contour. Laterally, This person was a little bit more generous with their lateral border, but that's okay. Posteriorly, the scalene muscle is your border. So that is how ideally you should contour the supraclavicular lymph nodes. So next, you have the axillary levels. So there are 3 axillary levels, 1, 2, and 3. And people also may include the internal mammary lymph nodes. So I just want to take a quick poll. How many people treat the internal mammary lymph nodes regularly?
No.
Pardon?
No.
No? Okay. So I find that the practice kind of split. So they've had some publications where they've shown that if you treat the internal mammary lymph nodes, there's some overall, after they've analyzed, lots and lots, thousands of patients, they come out with like a percentage, single digit percentage, around 7% improvement in the official statement of the RTOG is that they should be treated, but I find that it varies a lot. Some people base it on clinical findings. If the tumor is at the upper inner quadrant or lower inner quadrant of the breast, they may feel more compelled to treat the internal mammary lymph nodes. Especially if there was evidence of enlargement of the internal mammary lymph node at the time they did the workup, then people might feel compelled to treat. But I do find that a lot of people shy away from treating the internal mammary lymph nodes. So it's a clinical judgment call. So for the internal mammary lymph nodes, they run from the superior aspect of the first rib down to the superior aspect of the fourth rib. So essentially, like the first to fourth intercostal spaces. And you can see them here in the green. So you usually just contour out there are these 2 tiny vessels. Let me see if I can zoom in for you all. Can you see me zooming in? Do you see it zoomed in, everyone, in the green?
Yes, we can.
Okay,
Yeah.
great. So here you see these tiny vessels that run along the posterior border of the chest wall, and you just follow them and contour them out from the first to the fourth intercostal spaces. And that gives you a rough idea of where your internal mammary vessels are. So let me go back here. All right, and then when it comes to the axillary lymph nodes, the axillary lymph nodes go from levels 1, 2, and 3, like I said before. And when I start contouring, I usually start from level 3, which is the most superior, and I work my way down. So what I do is I scroll through until I've found the coracoid process, which is where the axillary level 3 inserts. It's not the cricoid, it's the coracoid. So hopefully I'll be able to show you that towards the end of this session. So I find where the coracoid inserts onto the pectoralis minor inserts onto the coracoid process. And then I start at that level and I contour the axillary level 3 so that it stops where the axillary vessels cross the medial edge of the pectoralis minor muscle. So on this image, this is the pectoralis major. Here is the pectoralis minor just sitting posterior to the pectoralis major. You can see here are axillary vessels. running medial and posterior to the pectoralis minor. And so what you want to do is you want to draw out the axillary level 3 until the axillary vessel crosses the medial edge of the pectoralis minor. So once you start seeing this region essentially be all gray without a vessel running through it, you should stop your axillary level 3 contour. When it comes to axillary level 2 contour, that begins when the axillary vessels have crossed the medial edge of the pectoralis minor muscle. So you can see here, there's crossing of the axillary vessels. So already this is axillary level 2. The anterior border of the axillary level 2 is the anterior surface of the pec minor. So as you can see here, you're including all of this. The posterior border is at the rib and pleural interface, and the lateral border is at the lateral edge of the pectoralis minor muscle. So this pink structure is your axillary level 2 contour. And so you're getting not just the lymph nodes that lie behind the that lie behind the pectoralis minor, you're also getting the interpectoral lymph nodes. Those are also considered level 2 lymph nodes. And finally, your axillary level 1 lymph nodes, those begin when the axillary vessels have crossed the lateral border of the pectoralis minor muscle. So you draw them out to make sure that they are beginning after the vessels have crossed the lateral border of the pectoralis minor. The anterior boundary is the kind of an invisible boundary of the anterior border of the pectoralis major and the latissimus dorsi muscle. So you just imagine a plane connecting these two muscles here and make that your anterior border. The posterior border of the axillary level 1 is the anterior surface of the subscapularis muscle. So this is what your level 1 lymph node should look like, okay? And you can see that there's overlap. You don't just have one lymph node level at any given time. There's overlap, and you can have all three depending on a patient's anatomy. So any questions about that?
Yeah.
Pardon?
Okay. Can go on. No question.
Okay.
Yeah.
Okay. So there are other sources that you can use for delineating the breast, the axilla, the internal mammary lymph nodes. So ESTRO, the European Society for Therapeutic Radiation Oncology, they have also put out a publication. So I shared the screenshot with you in case people want to look up this publication. Many of their definitions are the same, but they do define the breast as the anterior border being 5 millimeters under the skin surface, and we'll talk about why in a little bit. And they also just have a slightly different definition for where the supraclavicular lymph nodes begin, and they just explicitly say that you should connect the supraclavicular lymph nodes contour with the level 3 lymph node contour. So those are the main differences, but I don't think they really affect how the dosing or your ability to include all the levels. It's just slight differences in how things are defined. So when it comes to contouring, we want to make sure that we have a common language that we're speaking. And so in our profession, we have the definitions of the GTV, CTV, and the PTV. So GTV stands for the gross tumor volume. That means anytime you have a tumor that's still in situ, that's still within the patient, you draw that out as a GTV. In breast cancer, you may have a GTV if someone is coming for palliation because they, presented late. But usually, if you're trying to cure the individual, you won't have a GTV. What you'll start out with is a CTV, a clinical target volume. And so the GTV, to go from GTV to CTV, you usually add a margin for any subclinical invasion. So this is in the red is the GTV. To go from GTV to CTV, you add on a margin. Frequently, people use about 5 millimeters to account for any microscopic invasion of tumor that you may not be able to appreciate on your CT scan. Like I said, in breast cancer, we usually don't have a GTV. So what you're drawing by hand is considered your CTV because you're trying to treat any microscopic disease in the breast that may not have been, excised by the surgeon. But according to the surgeons, they always get the disease. So it is what it is. To go from CTV to PTV, what you're doing is adding a margin for setup error or for daily systematic errors in maybe the patient moves a little bit. So CTV to PTV is essentially expanded based on how confident you feel about your setup each day. So for instance, when you're treating a patient who has breast cancer, about a 5 to 7 millimeter PTV, CTV to PTV expansion is appropriate. Whereas if you're treating someone with a brain cancer, for instance, we immobilize them using a face mask, and that frequently doesn't allow for much motion. So they're more conservative with their CTV to PTV expansions, using anything like 2 millimeters, 3 millimeters, just less because you're comfortable about your setup. You're more confident that there's going to be less motion. So this illustrates, it's taken from one of the RTOG studies just to illustrate how you might contour out the breast clinical target volume. So based on the RTOG studies, this is how they usually do it. So you start out with a breast CTV, medial border, the rib and the sternal junction, lateral border at the mid-axillary line approximately, excluding the latissimus dorsi muscle. Anteriorly in the RTOG studies, like they also define it in the European guidelines, they do a 5 millimeter cropping off the skin. So the reason why they do 5 millimeters cropping off the skin is because when you give radiation therapy, once the x-rays hit the skin, they're not yet giving, sufficient dose. Sufficient dose comes after you've traversed about 5 millimeters into the body. So in order to, so that when you're evaluating your dose volume histograms, looking at how well you covered your target volumes, that you don't want to be penalized for this, natural, biological, physical phenomenon. So frequently people will just define the anterior border of the breast as 5 millimeters from the skin so that you can truly assess, you can more accurately assess the dose that you're giving. So once you've drawn out your breast CTV, you expand it by 7 millimeters to create your breast PTV, so CTV, PTV. And then you also create a breast PTV eval. So the reason you create the breast PTV eval is, again, because of the lack of sufficient dose being given until you're about 5 millimeters from the skin. So you use the PTV eval when you're looking at your dose volume histograms rather than the PTV because you'll get a reading like you're not giving sufficient dose to the breast unless you use the PTV eval. So the PTV eval is just the PTV cropped 5 millimeters from the breast, from the skin. So to review again, this is the breast CTV. To go from CTV to PTV, you're accounting for any margin of error in the patient setup. So we usually add about 7 millimeters. And then you create a breast PTV eval, which is the dotted line, cropped 5 millimeters from the skin so that you can account for that region of dose buildup. Okay? All right.
Yep.
So in terms of contouring guidelines, I just wrote out the structures that ideally should be included. And I'll say, let me just quickly, this should read lumpectomy. So let's talk quickly about breast doses. So there are a number of doses that are given in breast cancer. And I can just, since we're in this mode, I can just insert a slide. And do people mind saying what doses they give? For instance, if you have an early breast cancer, what are your common dose fractionations if you're just treating the breast in early breast cancer?
Your speakers are now open. You can speak.
So can anyone volunteer what dose they use to treat breast only?
For us in Ruth, sorry, this is Sonia. For us in Ruth, we use 45 in 18 fractions.
18 fractions.
45 gray in 18 fractions.
Okay, thank you.
Yeah.
No, 40 gray.
40 gray?
Yeah, in 15 fractions.
40 gray and 15 fractions. Okay, anyone else? Oh, where's the 40? Who's practicing with 40 gray and 15 fractions?
At Ocean Road.
Ocean Road, okay.
The rest of
Sorry, is it after conservative surgery or after mastectomy, early breast?
Oh, after conservative surgery.
after conservative surgery.
Yeah, we give a 45 in 22 with the boost therapy if the patient is younger.
Okay, so with boost therapy, what is your boost?
Boost is 10 gray in 3 fractions.
10 gray in 3 fractions. Okay. All right. Anyone else have any variations?
No.
Yes, we give 50 gray in 25 fraction in ABUTH Zaria.
Okay, 50 gray in 25 fractions.
ABUTH, yes.
Yes. Thank you. All right. So we can see that. Thank you all for speaking up. There are a variety of ways that people treat with early breast cancer. And so, I think 50 gray and 25 fractions is a common traditional way that people treat, very widely accepted. In the past decade, as we see in the other fractionation regimens, people have been looking at hypofractionation as a means of treating breast cancer. So initially there were concerns about what would be the toxicity to the breast in terms of cosmesis and also in terms of tumor control. So there have been some studies looking at that. And so there was one in particular that came from Canada where they used, and I'll put it here, I'll say Whelan T et al. And it was in their trial, what they did was 42.56 gray in 16 fractions. And so they have over 10-year data, follow-up data from that, and they showed that they randomized patients to either 42.56 gray in 16 fractions versus the 50 gray in 25 fractions. And what they found was that there was no difference in local control or overall survival for these women after over 10 years of follow-up. So that has actually led to a revolution in some places whereby they are treating women more and more with hypofractionation. So that's something you can offer, especially if patients are coming from a long distance, because I know, unfortunately, we have not enough radiation oncology centers on our continent. And hopefully that's something we're going to work on. And I have a lot of respect for all of you because I've seen firsthand the patient loads that you have to deal with as a result of this, this lack of machinery. But if someone is coming, let's say, from a long distance, it may make a big difference if they can finish their treatment in 3 weeks as opposed to 5 weeks. But again, there's a lot of variation in how people treat. This fractionation regimen by Ocean Road, 40 gray and 15 fractions, is also used. It was actually the point of study in my departments at NYU and Cornell. That's what we favor. And it was also used for RTOG studies 10005, which looked at 50 gray in 25 fractions versus 40 gray in 15 fractions. And they were also looking at so they looked at the hypofractionation as well. So that's been proven to be a reasonable regimen as well. And I think all of these regimens that you discussed, they all fall within the realm of a sufficient dose for early stage breast cancer. When it comes to locally advanced breast cancer, am I correct in thinking that many people just stick to 50 gray in 25 fractions, or are there people treating with other regimens?
Yes, at Ibadan, we use right now, because of the patient's load, we use hypofractionation when it is locally advanced.
Okay, so hello, Ibadan. Who's speaking?
Yeah, I'm taking.
Hi, Dr. Intakim, how are you?
Yeah, I'm fine, well done.
Dr. Intakim knew me when I was very young and had no idea what an X-ray was.
Yeah, congratulations.
Thank you. He's an excellent mentor. So thank you. I think people have shown that you can do hypofractionation for the breast, and that it's safe. But a lot of institutions in the United States are still very hesitant to do hypofractionation. I personally, embrace hypofractionation. I think multiple studies have already shown its safety, but it's just something to keep in mind. All right, so when it comes to contouring for the breast, these are the structures you want to make sure you have in place. So the breast/chest wall, and then you also want to create a PTV breast/chest wall, which is usually the CTV plus 7 millimeters. Then you want to make sure you also create a breast or chest wall PTV eval, which is what you're going to use to assess your plan and how well it covers the volume you want to treat. And so that's created by taking your PTV breast or chest wall and cropping it 5 millimeters off the skin. You also want to make sure you have your CTV axilla and your PTV axilla, which is the PTV plus 5 millimeters. You want to also make sure you draw out your ipsilateral and contralateral lungs, your heart, and then we also, because there's been a lot of interest in what is the dose to the heart, what is the dose to the left anterior descending artery, which is usually the main supplier of blood to the heart. The right coronary artery can also supply the heart, but it's not as common as the left. So we usually just focus on drawing out where we think the left anterior descending artery lies. You may also want to draw out your clavicular heads to help you as you're delineating the superior border of your chest wall. The lumpectomy CTV is also something that you can draw out. So in this image, people who employ a boost to the lumpectomy bed, either at the same time as they are giving the breast radiation or subsequently, they usually can draw out based on any surgical changes that you can see on your imaging. Sometimes there are clips like this white appearing thing here that help you delineate your lumpectomy bed. So you can draw out the lumpectomy bed, and you usually then expand it to a PTV by adding 1 to 2 centimeters to the lumpectomy bed. And you want to make sure that your lumpectomy bed CTV is not within 5 millimeters of the posterior field edge, because then that can compromise the dose that it receives. And as I discussed, if you create a lumpectomy PTV eval, you crop it 5 millimeters from the skin surface. And you want to always make sure that the lumpectomy PTV is inside the breast or chest wall PTV. All right, so this just talks about the lumpectomy PTV again. All right. So when it comes to breast cancer treatment field setup, this is a credit. Is there a way for me to share this this presentation?
Yes, I mean the slides, you want to share it with the class?
Yeah, I can share it after, send it to you, and then you can send it out, because this may be difficult to read.
Yes.
But in any case, I summarized the main points, which are that when you're treating the breast, the superior border should be, usually it's at the bottom of the clavicular heads, but again, you keep in mind that if in larger patients, for instance, it may extend superiorly to that. So you just want to make sure that your borders are covering the PTV of the breast. Inferiorly, you want to make sure that you have at least 2 centimeters below the inframammary fold, because as the breast is being treated, it can swell. And sometimes, if your border is, say, right here, if it swells, you have to go and create a whole new plan. Whereas giving some flash allows you to make sure that you're dosing the breast properly, and also allows for some swelling on treatment. Anteriorly, you also want to make sure you're giving, a flash of 2 to 3 centimeters. And the posterior edge is usually the rib cage. One of the tips that I've found in planning or setting up the treatment fields is that you can rotate the collimator. So you can rotate this field clockwise or counterclockwise, so that the posterior border matches, is kind of parallel to the rib cage, and that frequently helps with minimizing how much of the lung or the heart that you're catching. You can also, in some instances, rotate the couch itself because that will minimize the amount of arm that is being treated. Sometimes you're catching a lot of the arm, especially in large patients. And if you rotate the couch, you can come off the arm because that's normal tissue that you don't necessarily have to treat. When it comes to locally advanced cancers and treating the supraclavicular lymph nodes, you usually place the inferior border at the bottom of the cricoid cartilage. But again, you want to see where the PTV of the supraclavicular lymph node is and make sure that you're covering that. The inferior border is usually at the bottom of the clavicular heads. So you can see here, this is the clavicular head. So the inferior border is around there. Anteriorly, you want to make sure you're covering the lymph nodes, the PTV of your lymph nodes. It's usually at the skin. You want to make sure you give a little bit of, you're not right up against the skin. You're giving some flash as well. Medially, you go up to the ipsilateral vertebral body. And one thing is that you want to rotate the gantry for the supraclavicular field. You want to rotate that 10 to 15 degrees away from the spine so that you are not treating the spinal cord with full dose, especially if you're hypofractionating. So I think we said some of the regimens are giving 45 gray and 22 fractions. The spinal cord tolerance, max dose ideally would be around 45 gray, but that's calculated in 1.8 gray fractions. So if you're giving 45 gray and 22 fractions, you can't just accept a 45 gray maximum dose for the cord. You have to go a little lower because you're giving a higher dose than 1.8 gray per fraction. So just rotate the gantry 10 to 15 degrees for the supraclavicular field in order to make sure you're protecting the spinal cord. Other things to note are, I think a lot of people try to use a mono-isocentric technique. Are there many people out there who have to use two isocenters for treatment when they're treating the supraclavicular field as well as tangential fields?
No, most of the time you're using single isocentric.
Exactly. So the single isocenter, you know, when you place a single isocenter, you can do a half beam block technique to create a supraclavicular field and to create your tangential fields. And with the mono isocenter, you don't have to make shifts. So sometimes, you know, you can get in trouble. In my center also, you know, it introduces an opportunity for error if you have to use one isocenter for the supraclavicular lymph nodes and then shift, you know, around 5 centimeters inferiorly and use a different isocenter for the tangential field. So ideally you would have just a mono isocenter, one isocenter for both tangents and supraclavicular fields. But in case, if you have to have a dual isocenter, usually what we do is we shift about 5 cm inferiorly and from the supraclav isocenter, and that's how we create, that's where we create our tangent isocenter. But monoisocentric technique, the inferior border of the supraclav field is the superior border of the tangents. And you want to make sure that, again, the supraclavicular field rotate by 10 to 15 degrees. You also want to make sure there isn't divergence of your tangent fields. The posterior border of your tangential fields should be matched so that there isn't divergence into the lungs. So those are just some key points. In terms of plan evaluation, when you're treating the breast or the chest wall, you want to make sure that greater than 95% of the PTV breast or chest wall eval is receiving at least 95% of the prescribed dose. You also, and this is it whether or not you are doing hypofractionation. So these apply for hypofrac or for standard fractionation. When it comes to higher doses, the less than 30% of the PTV breast eval should get more than 100% of the boost dose. So those are some of your goals. If you're doing a boost to the lumpectomy bed, you want to make sure that the lumpectomy bed eval volume is getting at least 95% of the volume is getting 95% of the dose. You want to make sure that less than 5% of that lumpectomy bed is getting more than 110% of the boost dose. In terms of the maximum point dose, ideally, I strive for around 110% or less, but 115% is also acceptable. When it comes to the lymph nodes, on the studies, they're more lenient when it comes to lymph node coverage. So for the supraclavicular and axillary volumes, you want to make sure that 95% gets 95% of the prescribed dose. But if you can achieve that, then 90% of the supraclavicular or axillary lymph nodes getting 90% of the prescribed dose is acceptable. If people are treating internal mammary lymph nodes, they're even more lenient because it can be very difficult to minimize the dose to the lungs and the heart when you're including the internal mammary lymph nodes. So ideally, you'd have 95% of the internal mammary PTV getting 90% of the prescribed dose. If you can achieve that, then 90% of the PTV of the internal mammary nodes getting at least 80% of the prescribed dose is acceptable. So we talked about the supraclavicular field, giving dose to the lymph nodes in that region. If your level 2 axillary lymph nodes are not getting enough dose, if you find that you're far below what the dose is, what the ideal dose to the structure would be, then you can employ a posterior axillary boost field to increase the dose to that region. And what you would do is just copy and oppose the supraclavicular field, and then you would block along the clavicle so that you can increase the dose to the level 2 axilla. So that should be a way for people to boost the dose to the axilla using a second posterior field. In terms of your organs at risk, the contralateral breast, I'm always watching where my fields are going to make sure that the opposite breast isn't getting too much dose. And roughly, you want to make sure that the maximum point dose to that other breast is not more than 3 to 5 gray. Similarly, if you're doing hypofractionation, around 4 gray max is acceptable. With the heart, a mean dose, there are multiple parameters. I listed a lot of parameters that are acceptable for the heart dose, but if you have to remember one, a mean dose of less than or equal to 5 gray, I think is acceptable. When it comes to the lungs, if you're only treating with tangents, then your volume, the volume of the ipsilateral lung receiving 20 gray should be less than or equal to 20%. You also want to take a quick look at the low dose. The volume receiving 5 gray should be less than or equal to 55%. So if you just will, the one number I guess that trumps others would be the volume getting 20 gray. make sure that that's less than or equal to 20%. If you're treating the lymph nodes as well, then you have a little more room. Ideally, your volume receiving 20 gray should be less than or equal to 35% of that lung. So the contralateral lung, you shouldn't have any more than 15% getting 5 gray. There really shouldn't be dose going to the opposite lung. And the brachial plexus, the maximum dose is 60 to 66 gray. We usually don't get close to that when we're just doing 50 gray in 25 fractions or when we're hypofractionating. So this is an example of a dose volume histogram. So when I see a plan, I want to make sure that, if it's left-sided, that my mean heart dose is less than 5 gray. Here, the mean heart dose is 1.2 gray, which is good. This is a left chest wall plan. And we were treating the chest wall and the supraclavicular lymph nodes. So we wanted to make sure that the volume receiving 20 gray of the ipsilateral lung, the left lung in green, was not getting more than 35%. So I went to 20 gray. The volume getting 20 gray was about 30%. So that met my constraints. Also, the right lung, which is in blue, the volume getting 5 gray should not have been any more than 15%. So at the 5 gray line, there's no dose to the opposite lung, the right lung in blue. You want to also make sure that your PTV of the chest wall, our dose was 50 gray. You want to make sure that 95% of that volume is getting at least 95% of the dose. So in this case, 95% is actually getting 100% of the dose. So that's quite acceptable. And finally, one other thing, the left anterior descending artery, which is in the, let's see, it should be in the light green over here. That should be getting no more than, it should be getting a max dose of 15 gray. So that's what you want to make sure that your left anterior descending artery, especially if you have younger patients or people who run a risk of having cardiovascular disease, a previous heart attack, angina, diabetes, high cholesterol, you want to make sure you pay attention to what dose the heart and the left anterior descending artery are getting. And in this case, the left anterior descending artery was getting just 3.2 gray maximum, which is very much acceptable. So in terms of treatment verification, you can use onboard imaging if you have the imager enabled on your machine. Usually, I perform it at the first treatment, and then it's taken once again once every 5 treatments after that. There are differing practices amongst differing centers, so that's as long as it's done initially at the first treatment, and then every few treatments, that would be ideal if you have that capability. So those are some treatment verification images. Just to make sure, I make sure that the chest wall is where on the DRR, on the digital radiographic reconstruction, is the same as it was at the time of the CT simulation. So I compare, the CT simulation image with that day's image. I look at the chest wall. I look to make sure that the bottom of the breast isn't being clipped by the inferior border of the treatment field. I make sure that there's enough flash anteriorly for the breast. And those are the key things that I look at when doing treatment verification. So in summary, we have to balance cure with complications when we're looking at curative radiation therapy. Modern 3D radiation therapy with CT scans and MRIs as well as IMRT, but I favor using 3D for breast and IMRT if you really have to, because you can't meet those constraints. Let's say you want to include the internal mammary lymph nodes, and you just can't get a low enough dose. That's when I think IMRT might be warranted. Otherwise, 3D I think is just fine for the breast. CT simulation is important in order to establish the treatment position. And you should also contour the T structures, which we discussed, the CTV breast, create your PTV and your PTV eval, the heart, the lungs, etc. Make sure you pay attention to the DVHs and use imaging at regular intervals to verify your treatment setup. So that's it from me. If anyone has any questions, I'm happy to take them.
Okay. Your mouthpiece is now open. Your speakers are open now. Okay. Yeah. So my first question. Hi, Dr. Onyinye. Thank you very much.
Hi.
Yeah, this is credit actually, and I enjoy the class. Yeah. So, okay, I guess this one, my first question, I don't know if it's maybe also to everyone involved in the class, not just to Dr. Onyinye, is I'm really excited about this fractionation and the possibility of hypofractionation. So I wanted to know the economic side of it. Does it actually reduce the cost of treatment if you hypofractionate? Does it reduce the cost of treatment? That's my first question. So, and then is there, like, I don't understand, like you said, for instance, is there a minimum extent to which you can hypofractionate? For instance, is there any such thing as a single fraction breast treatment or something? Like, to what extent can you hypofractionate? So that's my question. And then the economic implication as well.
That is a great question. So when it comes to I think it differs. It's all based on how your system is set up, right? Yeah. So in our system, in the system in which I practice, for us it doesn't make a difference if I hypofractionate or if I don't. So I just hypofractionate just to save patients time. But I know, for instance, I collaborate with some colleagues in Armenia, and for them, they get paid per treatment. So my colleagues get paid per treatment, and if they get paid per treatment, they've told me explicitly that they don't have an incentive to hypofractionate. So that's something that might drive it. Your other question was to what extent can you hypofractionate? So when it comes to hypofractionation, right now the limit that we're pushing is 15 fractions. Right now the limit that we've pushed is to 15 fractions. When it also depends on the volume of the breast that you're treating. Okay. So when we're treating the whole breast, the lowest I've seen is about 15 fractions for ours. There was a paper produced by someone from New Jersey. His name is Bruce Hafty, and I think he looked at 10 fractions of about 3 point something gray a piece. I'll try and find the exact amount, but he has kind of pushed it a little bit more. If you're treating just partial breast, you can hypofractionate even more. So at our center, we know that there's some patients who have very low risk of recurrence. So these are patients who have T1 disease, 2 centimeters or less, who are estrogen and progesterone receptor positive. And I know that not all centers have the ability to stain for ER/PR positivity. But if we're able to, and we can confirm that this person, in fact, has a small tumor burden, 2 centimeters or less. They're ERPR positive, and they don't have any positive lymph nodes, then we usually treat just the lumpectomy bed, and we treat that with 5 fractions of 6 gray apiece. And that hasn't been shown to have worse side effects or worse cosmesis compared to like 15 fractions of breast radiation. And the recurrence rate was 1% at 5 years. So it doesn't compromise the recurrence rate either. And then there's some places where they do intraoperative radiation therapy. That's not yet as widely accepted as external beam, but with intraoperative, they give 1 fraction of 20 gray. So it depends on the volume of breast that you're treating. The smaller the volume, the smaller, the lower number of fractions and the higher the dose you can give. But I think about like 15 is a standard hypofractionation regimen.
So I don't know if anybody has any question, because I have 2 more. So, hello? More questions?
Yeah, please, I have a question.
Okay, great.
Yeah. All right. Here in Nigeria, my name is Hayatu Mohammed. I'm a medical physicist here in Nigeria, University of Medical Teaching Hospital. My name is Hayatu Mohammed.
Oh yes, good evening. I heard you. Good evening, Hayatu. I'm happy you're on the call.
Yeah. All right, thank you. Actually, I'm a physicist here with University of Medical Teaching Hospital. We're still waiting for a therapy machine. Well, I'm a really interest because I actually proposed to do my PhD in optimization on advanced radiotherapy. One thing I realized back home is about this treatment verification, because most of the machines we have here in Nigeria, we don't have on board treatment verification. I don't know if my talk more on that. So now you have board treatment verification. What other options do you have for verification? Thank you.
So that's a great point. Hayatu, did you finish your question? Hello?
Yeah, please, I do. Yes, finish.
Yes, so that's a
I'm finished.
If you don't have on treatment onboard imaging, one other way you can verify is you can use your light field. For instance, look at the light field for the supraclavicular lymph node. That's one thing you should do. Make sure, like, sometimes we have patients whose chins come down, and if the chin is being treated and is in the way, that's a problem. So make them tilt the chin up and out of the way. So one thing you can do is to use the light field as well, to do a rough approximation that you're in the correct place. Hello?
No.
Yeah, I'm listening.
Yeah, so I think the light field can be one resource. And then I'd love to hear from other people, because clearly my experience has been based a lot on onboard imaging. But I'd love to hear from everyone else how else they can verify that the patient has been placed in the right position. Clearly, like if you tattoo patients, you hope, you use those as a surrogate to see that you're in the right area. But maybe aside from tattoos and aligning to the tattoos, and also light fields, I'm not sure what else, but I'm willing to hear from others, and I can also look into that issue as well.
All right, thank you very much.
No problem.
All right.
So one more question. Is there really any difference between contouring on a 2D CT plan and a 3D? Like, how does it differ if you were to move from, okay, we discussed the 3D, but on a 2D, is there any different protocol for contouring or method?
So when you're doing 2D, you would take a wire, right? You take a wire and create an outline. Oh, as I've seen it practiced, right? In the institutions that I was in, and I think there are maybe different ways to do it. A wire would be used to create the patient's outline, and then you transfer that onto a piece of paper. So when you're contouring in through 2D, what they usually were doing was to use a machine to kind of go along the wire surface that you drew out and put that into the computer. I don't think you can't see soft tissues. You can't see the lungs. You can't see the heart clearly when you're doing 2D. But if you get a 3D image, like a CT scan, you can see the heart, you can see the lungs, you know. It would also be difficult to see the lumpectomy bed, for instance, when you're, you know, kind of taking an outline of a person and transmitting it onto a paper or into your that outline into a computer.
Right. Yeah. Thank you. Okay. Any more questions?
So someone sent out a question about how long. So there were two questions I wanted to address. How long does it take? Process takes. So someone asked about how long does it take to 3D plan a case, considering, and they're thinking about this because of the patient volume at their center. So I agree, to go from 2D to 3D requires a lot more resources and a lot more time. So the first step would be the CT simulation, where you bring the patient in and you put them in the position in which you're going to treat them, and you create the immobilization devices. So if you have someone who's going to be on a breastboard, you put them on a breastboard. So that CT scan takes about 1 hour. And then from there, the physician or the trainee has to draw out, you know, those contours I mentioned, the heart, the lungs. So drawing that out, you know, can take about an hour. When you're first starting, it can take longer. So that's about, let's say, 2 hours now. The long part is the planning process. So to throw on fields and to do the calculations can take a few days. And then you also have to allow physics to do their treatment plan approval. So you need more resources, you need more time. Usually we tell patients from the time that they've done their CT scan, they should give us about 1.5 weeks before they can start treatment. So it definitely is a bigger tax on the system. And yeah, it has to have everything. It has to have a lot of people on board, and it takes more time than the 2D process. One more person asked, they said that I focused on the intact breast. So is there any difference when you have a mastectomy? So when you've had the mastectomy, I think I pointed out the chest, what you're drawing out is the chest wall contour instead of an intact breast contour. And you want to, let me pull it up again. Can I share my screen?
Sure.
I can share my screen, right?
Yes.
Okay. Here we go. Hopefully everyone can see it again. So when you're contouring in a post-mastectomy setting, you want to contour what in the purple, the chest wall. So you want to include medially up to where the rib meets the sternum, laterally the mid-axillary line, making sure to not include the latissimus dorsi, anteriorly up to the skin, and posteriorly including the ribs and also the pectoralis muscles, the major and the minor. So the dose that you would give, whether you hypofractionate, could be the same, but it's still the same principles that apply when it comes to dosing, when it comes to making sure that the PTV of the chest wall is getting a sufficient dose. So when you've outlined your chest wall, you can make the CTV by cropping it 5 millimeters off the skin. Then you expand it by 7 millimeters to create a PTV of the chest wall. And then you have to crop it again 5 millimeters off the skin to make a PTV eval. So the same principles apply. You want to make sure 95% of your PTV chest wall is getting 95% of the dose. So that doesn't change. And the maximum dose should be less than 115% ideally. And these, if you're treating mastectomy, if they had a mastectomy and they had positive lymph nodes, again, the volume getting 20 gray of the ipsilateral lung should not be more than 35%. If they had a mastectomy for early stage disease, like a T1 or T2 and 0, I would not treat them with post-mastectomy radiation unless for some reason you think that there may be gross disease left behind and that the surgeon did not do a sufficient surgery. In that case, I would even recommend that you send them back to the surgeon or do a re-excision rather than treating them with post-mastectomy radiation, because post-mastectomy radiation can't compensate for gross disease that's left behind. Let's see. I hope that answers that. Is there any difference in terms of side effects while comparing the two fractionation regimens in the study? So I assume that you're talking about the 42.56 gray hypofractionation versus 50 gray. I think that was Dr. Lulabuka. Oh no, that was not Dr. That was Dr. Adeniji Adeoluwa. So there was no difference actually in terms of cosmesis. Other studies have actually found that hypofractionation may have a lower rate of side effects like dermatitis and improved quality of life. So some studies have found that hypofractionation improves quality of life than can improve quality of life compared to long-term, like 5 weeks of treatment. One moment. Okay, let's see. Dr. Lulabuka asked if there was any, what is the indication of boost axillary dose? Okay, Doctor, what is the indication of boost axillary dose, and what is the dose? So, let's see. I think when you let me put up my presentation again. So you want to give increased dose to the axilla if it's getting if it's getting like 85% of what you want the axilla to get. So what I mean by that is, let's say you're evaluating on your DVH, what's the axilla level 1 getting? What's the axilla level 2 getting? What's the axilla level 3 getting? So I like to draw each axillary level out, because sometimes if you just say, oh, the axillary volume, you may not be able to tease out that the level 3 is kind of getting a lower dose than it should be. So I like to assess each axillary level on its own, and we want to make sure that about 95% of that volume is getting 95% or more of that prescribed dose. Or if you can't achieve that 90% is getting 90% of the prescribed dose. So if your axillary level is getting less than 90%, less than 85 to 90% of that dose, then you need to add the posterior axillary boost field. And so let's say you want to give 50 gray via the let the axilla get 50 gray. So usually they give it about 10 gray posteriorly. They let it be about 10 gray coming from the posterior aspect of the field. So people vary in how much, but it definitely is not nearly 50% of the dose coming from there. You should not have 25 gray coming through your PAB. It's usually about like 10 gray coming posteriorly from the PAB. Let's see, one moment. One other question was, this is a great question. Does a large volume breast, from Dr. Adeniji Adeoluwa, does a large volume breast or pendulous breast affect the boundaries of the tangential fields, the immobilization device used, or or the dose distributions or possible doses to the organ at risk? So that's a great question. I actually want to show you, let me show you all. I didn't go into this because I think probably most people are not using it. In fact, in the United States, most people are not using this form of treatment for their breast, but it's gaining popularity. So let me just show this for informational purposes, and let me plug in my laptop so that it doesn't die while we're talking. Let's see. Okay. So this is looking at prone breast. So for women who have large pendulous breasts, can everyone see can everyone see it?
Yes.
Okay. So you can see this, right? When you're treating the left breast in the supine position, there's a risk for, you treat the lungs and you also cut through the heart. And right around here is where that left anterior descending artery sits. So this is it on the DRR. You're cutting through the lungs, you're cutting through the heart. But they have a new way of treating patients, which is prone breast radiation. And this has gained popularity starting in like the mid-2000s. So you can see this same patient was stimulated in the supine position, and this is where the treatment fields, went through, because you want to treat up to the mid-axillary line, and you also want to treat up to the, junction of the rib and the sternum. Pardon?
Yeah, we can hear you.
Okay, you're able to spare more of the heart and the lung tissue by putting them in this prone position. And at the moment, I'm actually in Gabon, and we're launching this prone positioning for patients here in Gabon. So it's pretty exciting. But this is just another example. If someone has a pendulous breast, you can get a lot of inframammary fold desquamation. But putting them in this prone position kind of decreases the risk of that,
Please, I can see the screen.
We can
see that.
Hello?
Yes?
I can.
I'm not seeing the screen. What your demonstration? It's your presentation, that's the slides. It's showing.
That's showing? Okay, so let me stop sharing and start sharing again. Let me start sharing again.
I'm not sharing.
Okay. How about now?
No way.
No.
It's showing.
Okay.
Okay, now it's showing.
Now we see it.
Okay. So great. So this
Yes.
phone, you see on the left, thank you. You see on the left the supine positioning, going through the heart, it's going through the lungs. But the same patient in the prone position, the heart, the breast pulls away from the heart and the lungs, and so you're better able to spare the heart and the lungs in the prone position. You also, in people who have pendulous breasts, you create this build-up region because of the inframammary folds, and you can have the significant moist desquamation in this area. But by going in the prone position, you eliminate that issue. And it also makes the breast more homogeneous, and I've found that it makes planning easier when we do the prone positioning for these large-breasted patients. But there were studies done that show that it helps both people who have large breasts and those who don't have, very large breasts. They did a study of 100 patients, putting them in prone versus and found didn't if you had small breasts or if you had very large breasts, at all sizes, there was a benefit to the prone positioning. So that's, and so you use a different Dr. Adeoluwa, you use a different board, you use the prone breast board if the patient has a pendulous breast. But usually I use the same boundaries. Superiorly, inferiorly, you still want 2 centimeters of flash. Anteriorly, you want 2 centimeters of flash. So it doesn't really change the borders too much, but it decreases the dose to the heart and the lungs. Does this, one person asked, Dr. Seppo? Okay. Dr. Seppo asked this thing is, I'm trying to read the question. Is there any contraindication to use RT and breast cancer? So great question. I think I'd be hesitant to use radiation therapy in breast cancer patients. For instance, if the person had a history of scleroderma, or active lupus. Hello? Yeah, if the patient had a history of scleroderma or active lupus, they have a significant risk of having fibrosis of the breast. But I think even in those instances, depending on what stage the disease of the breast cancer is, you may just want to counsel them about the risks of the treatment, the risk of fibrosis, etc., rather than, just saying you shouldn't have radiation at all. If they have early stage disease and maybe they had breast conserving treatment, then you may, in that case, if they have active lupus or scleroderma, you may want them to go for a mastectomy so that they can avoid having radiation therapy. So those are cases where I may not suggest breast cancer radiation therapy. I hope that's sufficient. How often, Dr. Ella Nwachukwu asked, how often do you do portal imaging throughout the treatment? And what do you do when you have scars extending to the posterior axilla? Great question. So I do portal imaging at the first treatment and then once every 5 treatments. If I have scars that extend to the posterior axilla, I feel like any scar has to be covered. So that's one of my basic tenets of radiation therapy treatment. It's problematic because if someone, maybe the surgeon doesn't have oncologic experience, and that's why the scar is extending that far. But if it's whatever scars are present, you have to make sure that it's covered. So what you need to do is make sure that at the time of CT simulation that you wire the scars. So I make sure to wire any scars that are present at the time of CT simulation so that I can make sure that the field is covering them once I put on my treatment fields. So that's one thing. Does the scar length also affect the contouring for the tangential field, and how do you make up for the very extensive mastectomy scar? So you have to make, it does affect your tangential field if it extends, you know, hopefully it's not crossing the midline. If it is, then maybe you have to make a clinical judgment to cut off some of the scar. You wouldn't want to start treating the contralateral breast and normal tissues too much. But if it's extending posteriorly, then you can hopefully just use your field, adjust your field to include where the scar is. Someone said they're not is radiation therapy contraindicated in patients with previously treated rheumatic heart disease or patients currently having a cardiac pace setter? Great question. So I'm guessing that maybe the patient who had rheumatic heart disease got treated with radiation therapy previously. What dose do they usually receive, Dr. Adeolua? So I'll set aside the rheumatic heart disease and I'll talk about the pacemaker. So if someone has a pacemaker in place, there are, you know, you want to constrain the dose to the pacemaker. If it's on the same side, I don't know how feasible it is in the different settings, but if it's on the same side, we will inquire about moving the pacemaker. That's one of the things we may ask about. If the pacemaker is on the same side, but it seems like it may be out of the field, one thing we do is we will measure the dose to the pacemaker on the day of the first treatment. So you can use a diode or a thermoluminescent dosimeter or MOSFET, just something to try and measure the dose to the pacemaker. And then you can look up each pacemaker. Many of the companies have reports or guidelines about how much is the maximum dose that can go to that pacemaker. So working with your physicist, you can usually try and create a plan to ensure that you limit the dose to the pacemaker. And then another strategy is to move the pacemaker. I'm not sure how feasible that is in the different settings, but those are strategies that I've found you can employ. Is there a difference in radiation therapy treatment planning for breast cancer that has metastasized, for instance, to the brain? So when the breast cancer has metastasized to the brain, usually the treatment in general, the goal is now palliation, right? So you want to, if the patient is not symptomatic in the breast, I will usually not bother with treating the breast. If it has already metastasized to the brain, I will send them for chemotherapy, and that is what I will focus on them getting chemotherapy, and hopefully the chemotherapy can somewhat address the breast cancer as well. If it's been some time and they have demonstrated that they're surviving for a long time with no metastatic sites that pop up that are new, I may then consider doing something definitive like a hypofractionated course to the breast itself. 15 fractions, 40 gray is a common regimen. 16 fractions, 42.56 gray. There have also been studies looking at if someone has metastatic breast cancer, does radiation therapy to the breast make a difference? And there was a study out of India, Tata Memorial Hospital, that didn't show any improvement in overall survival if you treated someone who had metastatic disease that responded well to chemo and subsequently got radiation. So we still don't have any level 1 randomized trial evidence that says that you should treat breast cancer that has metastasized. I would treat them. The only time I feel strongly about treating them is if they present with, ulcerating mass that's large, that's painful. That's when I focus on getting the breast treated as well. Otherwise, the main idea is chemo. Could we use electrons for the scars extending posteriorly to possibly avoid the lungs? And if yes, do we do that concurrently or sequentially? So fair question. When it comes to the scars that are extending posteriorly, if you wanted to use electrons, that would mean, in addition to the tangential fields, that would mean a match, and you could use that. That's one strategy you could use if you found your lung dose was too high. You'd want to probably make sure you use the 2 centimeter. You leave the 2 centimeter margin around what will be your electron field, but it's, I think, in the setting, if you probably, this is where IMRT would be probably very useful, but IMRT, just matching with electrons is not abstract, and I would probably do that concurrently because if you have, let's say, your normal field, and then there's a small patch of, let's say, 3 centimeter lateral scar extending posteriorly, you want to make sure that you cover that at the same dose. You want to just boost those because microscopic breast disease should at least be treated to, hypofractionated 40 to 45 grade. If you're going to give a standard fractionation, you should take it to 50 gray if that's what you're going to do. So you want to extend the treatment time. You should do the additional portion of the scar sequentially. Just do that at the same time and ensure that you have, if you have an unmatch, you should feather the field. So move the field probably up to 25 fractions, move the field, move the tangential field immediately, and move the electron field immediately as well, so that you don't have a hot spot that kind of takes out or compensates for any cold spots that developed. So it depends. A question about if you use the posterior border of the tangential field to cover it, what amount of the lung would be included.
Hello. Hello. Hello.
We can't hear.
Yeah, I think we just missed her. But we had already gone beyond the time limit anyway.
Yeah, I know.
Okay, great. Can everyone hear me, please?
Yeah, we can hear you.
Okay.
I can hear you.
Yeah, good. Thank you. I can't hear her either, but I think that's because we've gone beyond the time limit. This is supposed to be 1 hour.
Yeah,
it's almost.
It's like we've lost her.
Yes.
Yes.
I'll get in touch with her quickly, but I just want to say maybe further questions. She will create time for her to answer further questions, and then we'll also create time for practice, real-time practice of what she has been teaching. So we've resolved that we're going to use the ProNo software, and so hopefully by October we're going to have an account for everyone on ProNo. and then you're able to practice all of this you've practiced. And we'll bring back Dr. Onyinye, who would be able to take some tutorials in real life. I mean, the real life practice of what she has been saying, and then possibly she may also be able to take some private tutorials, and whatever questions we have may also be addressed. Okay, I think Dr. Onyinye is back.
Okay.
Hello. Okay, she's still not online. All right. Thank you very much. I know we have a lot of questions, but any further questions, we can all contact her.
Okay. Thank you.
Thank you very much. So we've come to the end of the class. I want to thank you for your patience, and we'll keep in touch online. And I'll forward the lecture notes, and we'll arrange for this video to be forwarded to all of us. We can watch it over and over again, and those who miss the class can also be able to see the lecture notes and the videos as well.
Oh, thank you.
Okay.
Okay, thank you.
Bye.
Thank you very much.
Bye.
Thank you very much. Bye.
Thank you.